Good morning. The topic for today's presentation is Histopathology of Vesiculo-bullous disorders. So, histopathologically, vesiculo-bullous disorders can be classified based on anatomical level of split, mechanism responsible for the split, and inflammatory cell component. And this is mainly for subepidermal blisters. Based on anatomical level of split, the vesiculo-bullous disorders can be classified mainly as intraepidermal blisters and subepidermal blisters. Among intraepidermal blisters, it can be at the level of subcorneal or granular layer, spinous layer, or suprabasal layer. Under subcorneal or granular layer comes pemphigus foliaceus and its variants, IgA pemphigus, subcorneal pustular dermatosis, staphylococcal scalded skin syndrome, and bullous impetigo. Under spinous layer comes IgA pemphigus, Hailey-Hailey disease, incontinentia pigmenti, epidermolytic hyperkeratosis, spongiotic dermatitis, and herpetic blisters. And in suprabasal blister comes pemphigus vulgaris and its variants, paraneoplastic pemphigus, Darrier disease, Grover disease, and Hailey-Hailey disease. Coming to subepidermal blisters, the blisters occurring due to basal keratinocyte necrosis, cytolysis, or damage include epidermolysis bullosa simplex, erythema multiforme, and thermal injuries. Then blisters occurring due to epidermal basement membrane zone disruption can be further classified depending on the level of split. At lamina lucida, it includes bullous pemphigoid, cicatricial pemphigoid, herpes gestationis, dermatitis herpetiformis, linear IgA dermatosis, epidermolysis bullosa junctionalis. And at the level of sublamina densa, it includes bullous LE, epidermolysis bullosa acquisita, linear IgA dermatosis, epidermolysis bullosa dystrophicaన్స్, porphyria cutanea tarda, or pseudoporphyria. And coming to dermal level of split, it may be iatrogenic induced by penicillamine or bullous amyloidosis. Next is based on the mechanism responsible for the split. The various mechanisms that can cause splits include spongiosis, acantholysis, reticular degeneration, cytolysis, basement membrane zone destruction. Spongiosis causes splits in eczematous dermatitis, miliaria, early pemphigus, and some pattern of transient acantholytic dermatosis, that is Grover disease. Acantholysis is a mechanism responsible for the split in pemphigus. Some patterns of transient acantholytic dermatosis, Hailey-Hailey disease, Darrier disease, and some cases of irritant dermatitis. Reticular degeneration is a mechanism in viral infections and eczematous dermatitis late stage. Viral infections can also show ballooning degeneration. Then cytolysis is a mechanism responsible for the split in epidermolysis bullosa simplex, epidermolytic hyperkeratosis, friction blister, erythema multiforme, some cases, and some cases of irritant dermatitis. Basement membrane zone destruction is the main mechanism responsible for the split, particularly in subepidermal blistering disorders. This include bullous pemphigoid, cicatricial pemphigoid, linear IgA dermatosis, dermatitis herpetiformis, EBA, epidermolysis bullosa letalis, that is junctionalis, and dystrophicaన్స్. Then based on inflammatory cell component, it can be divided. This is mainly for subepidermal blistering disorders. This can be further divided into subepidermal bullous disease with acellular dermis and those with cellular dermis. Under acellular dermis comes porphyria cutanea tarda, epidermolysis bullosa dystrophica, friction bullae, non-inflammatory bullae of bullous pemphigoid, non-inflammatory bullae of EBA. Then those with cellular dermis can be further classified based on the nature of inflammatory cell component. This may be subepidermal bullous disease with eosinophils, polymorphs, lymphocytes, mixed infiltrate, or mast cells. So those with eosinophils include bullous pemphigoid, herpes gestationis, and some cases of IgA bullous dermatosis of childhood. And those with polymorphs or neutrophils include dermatitis herpetiformis, linear IgA bullous disease. Then those with lymphocytes include erythema multiforme, EBA, and bullous LA. Subepidermal bullous disease with mixed infiltrate are EBA or bullous LA and bullous pemphigoid. And those with mast cells are bullous mastocytosis. So coming to the disease proper, first intraepidermal blistering disorders. First is pemphigus vulgaris. The earliest change in pemphigus vulgaris is edema and disappearance of the intercellular bridges of keratinocytes in the lower epidermis, leading to acantholysis. The established lesions of pemphigus vulgaris shows suprabasal bullae with acantholysis. Though the cells of suprabasal keratinocytes lose contact with each other due to loss of desmosomes, they retain their contact to the basement membrane via hemidesmosomes. This gives rise to the appearance of row of tombstones. The intraepithelial acantholysis can extend into adnexal structures, and it can go higher up to the stratum spinosum. Then within the blister cavity, there may be acantholytic keratinocytes. They may be single or in clusters. They have a rounded condensed cytoplasm, enlarged nucleus with peripherally palisaded chromatin and enlarged nucleoli. Occasionally, few eosinophils or neutrophils can be present in the cavity. And in the dermis, there is usually a mild superficial mixed inflammatory cell infiltrate that usually includes scattered eosinophils. The dermal papillae, which is lined by a single layer of basal keratinocytes, may protrude into the blister cavity, which is called as villi. And rare changes in pemphigus vulgaris include eosinophilic spongiosis and subepidermal splitting. So the image shows suprabasal splitting with a single layer of basal keratinocytes showing row of tombstones appearance. Next is pemphigus vegetans. It is a variant of pemphigus vulgaris. So it is of two types, Halopu type and Newman type. So the histopathology can be divided into early lesions, and those of early lesions and those of vegetative or advanced lesions. In early lesions, Halopu type shows transmigration of eosinophils into the epidermis and formation of spongiotic microvesicles and eosinophilic microabscesses. These microabscesses contain charcot-laden crystals. In the Newman type, there is intraepidermal vesicles with suprabasal acantholysis, but unlike Halopu type, it doesn't have eosinophilic microabscesses. And in advanced lesions of pemphigus vegetans, it is similar for both types with hyperkeratosis, some papillomatosis and prominent acanthosis with downward proliferation of reteriches. Then suprabasal lacunae may contain some eosinophils and few acantholytic cells may be present, particularly in the Newman type. So in the image, the red arrow shows the thickened epidermis showing pseudoepitheliomatous hyperplasia, and the blue arrow shows, the second image is a zoomed in version of the first one. The blue arrow shows suprabasal blister with inflammatory cells in it. Then pemphigus foliaceus. The earliest change in pemphigus foliation is formation of vacuoles in the intercellular space in the upper layer of epidermis. These vacuoles may then expand, leading to cleft formation, forming subcorneal blisters. Few acantholytic keratinocytes may be found attached to the roof or the floor of the blister, and these may be almond or spindle shaped. The blisters can also form within stratum granulosum, and in this case, sometimes a missing stratum corneum with few acantholytic keratinocytes may be the only finding. The deeper epidermis is usually intact, but secondary clefts may develop in the deeper epidermis also, and this may lead to detachment of epidermis in the mid-level, and rarely it can go up to the suprabasal layer. Then eosinophilic spongiosis can also be seen in very early lesions of pemphigus foliaceus. And the dermis shows a moderate number of mixed inflammatory cells, which usually include eosinophils and neutrophils. In the late lesions of pemphigus foliaceus, there may be hyperplastic epidermis with overlying focal parakeratosis and some orthokeratosis. Then dyskeratotic cells with hyperchromatic nuclei, which resembles grains which is found in Darius disease, are also a distinctive feature in case of pemphigus foliaceus at the level of granular layer. In the image, the red arrow shows subcorneal blisters seen in pemphigus foliaceus, and in the second image, the split is at the level of the blue arrow showing split at the level of granular layer, and in this picture, the stratum corneum is absent, and the dyskeratotic cells which resemble the grains in Darius disease can be seen in the image. IgA pemphigus. So it is of two types, subcorneal pustular dermatosis type and intraepidermal neutrophilic type. Then two distinct histopathological patterns are observed which parallels the clinical presentation. In SCPD type, subcorneal vesiculo-pustules or pustules are present, and intraepidermal neutrophilic type contains intraepidermal suprabasal vesiculo-pustules or vesicopustules or pustules, which may involve either the lower epidermis or it may spread to involve the entire epidermis. The contents of pustules are usually predominantly neutrophils, and acantholysis is usually not seen. So in the first image there is subcorneal blister in SCPD type of IgA pemphigus showing collection of neutrophils, and in the second image shows intraepidermal neutrophilic type of IgA pemphigus showing intraepidermal vesicopustules and neutrophils. SCPD, subcorneal pustular dermatosis. Here also there is subcorneal pustule filled with neutrophils and occasional eosinophils. The pustule appears to sit on the epidermis and usually causing no depression to the epidermis. Occasional acantholytic cells may be present in older lesions. When compared with pustular psoriasis, mitotic figures are usually absent within the epidermis, and a mixed superficial perivascular inflammatory cell infiltrate is present in the underlying dermis. So, SCPD and SCPD type of IgA pemphigus can be differentiated based on the direct immunofluorescence findings. It will be negative in SCPD. Next is paraneoplastic pemphigus. The histologic features are variable depending on the clinical presentation. It may have unique combination of EM-like, lichen planus-like, pemphigus vulgaris-like, and pemphigoid-like features. The main finding is suprabasal acantholysis with basal apoptosis, which may be associated with an interface dermatitis as an erythema multiforme with or without lichenoid band-like infiltrate. Rarely it may present exclusively with lichenoid interface dermatitis without acantholysis. And in pemphigoid-like variant, subepidermal blister may be present. So the image shows, blue arrow shows suprabasal acantholysis, and the red arrow shows interface dermatitis. Staphylococcal scalded skin syndrome. Here it produces a subcorneal blister. Usually it is very difficult to obtain an intact blister because the stratum corneum may be lost during the biopsy procedure or due to subsequent processing of the specimen. Few acantholytic cells and neutrophils may be usually present in the intact blisters or on the surface of epidermis if the roof, that is stratum corneum, has been shed. Usually this is toxin mediated, and usually organisms are not present in the affected skin in contrast to bullous impetigo. And the inflammatory infiltrate is also very sparse in the upper dermis, whereas in bullous impetigo and pemphigus foliaceus, the infiltrate is usually heavier. Bullous impetigo, it also produces subcorneal bulla but with a dermal inflammatory response. The acantholytic cells in the superficial epidermis accompanying degenerated keratinocytes and small number of neutrophils are present. Here, in contrast to SSSS, gram-positive cocci may be seen within the superficial epidermis. The image shows subcorneal bulla seen in bullous impetigo. Hailey-Hailey disease. It is an inherited acantholytic disorder, and the early lesions show small suprabasal separations called as lacunae, and the fully developed lesions leads to large separation in a predominantly suprabasal position. So the cells, even though there is extensive loss of intercellular bridge, the cells at some places only have a slight separation between them because they are still being loosely held together by a few intact intercellular bridges. So this gives rise to the appearance of dilapidated brickwork. Within the bullous cavity, there may be single or group of cells. When compared to diarrhea disease, necrotic keratinocytes are uncommon, and rare acantholytic dyskeratotic cells like choroids may be observed. In more chronic lesions, there may be epidermal hyperplasia, parakeratosis, and focal crus. Here also, similar to pemphigus vulgaris, the dermal papillae lined by single layer of basal cells protrude into the blister cavity called as villi. Then a moderate perivascular lymphocytic infiltrate is observed in the superficial dermis. So the image shows acantholysis beginning in the suprabasilar area and extending throughout the epidermis. Next is diarrhea disease. It is also an inherited acantholytic disorder. The two prominent histological features seen in diarrhea disease are acantholysis and dyskeratosis. Acantholysis leads to suprabasilar cleft formation. Dyskeratosis is an abnormal keratinization. It is characterized by nuclear condensation and perinuclear keratin clumping. So this keratosis produces two types of dyskeratotic cells in diarrhea disease, which are choroids and grains. Choroids are acantholytic enlarged keratinocytes, which are seen in the malpighian layer, and it contains darkly staining, partially fragmented nuclei, which is surrounded by a clear cytoplasm, and it is encircled by a bright ring of collapsed keratin bundles. So in the second image, the yellow arrow shows choroids. So you can see the darkly staining nucleus surrounded by clear cytoplasm and which is surrounded by a bright ring of collapsed keratin bundles. Then grains. These are small oval cells in the stratum corneum. It contains an intensely eosinophilic cytoplasm which is composed of collapsed keratin bundles and contains shrunken parakeratotic nuclear remnants. The green arrow in the second image shows choroids. The epidermis overlying acantholytic and dyskeratotic foci is thickened with papillomatosis and hyperkeratosis, and the superficial dermis may show mild to moderate perivascular inflammatory infiltrate. Next is Grover disease. Grover disease is a histopathological differential diagnosis of both Harrier and Daly. It is also called as transient acantholytic dermatosis. Histologically, four major patterns are seen: diarrhea disease like, Haley disease like, pemphigus vulgaris or foliaceous like, and spongiosis with acantholysis. Rarely, acantholytic cells that appear multinucleated may be seen, which are called as pseudoherpetic variant. When compared to diarrhea disease, it has more acantholysis, less dyskeratosis, and fewer choroids and grains, and there is presence of eosinophils within inflammatory infiltrate, then it favors Grover disease. When compared to Haley, histologically both may be indistinguishable from each other, but they can be easily distinguished clinically. And when compared with pemphigus vulgaris or foliaceous, it can be differentiated using DIF. Grover disease has a negative DIF. Herpes simplex, zoster and varicella, all these three have similar histopathological findings. The earliest change is nuclear swelling of keratinocytes. This produces slate grey. In HND staining, it produces slate grey and homogeneous nuclei with margination of the nuclear chromatin. The split begins in basal keratinocytes and then spreads on to involve the entire epidermis. Later, profound degeneration of keratinocytes lead to acantholysis and vesicle formation. So, it shows two types of degeneration: ballooning degeneration and reticular degeneration, both leading to secondary acantholysis. So, ballooning degeneration is the keratinocytes become swollen and they lose contact with each other with space forming in between them, leading to secondary acantholysis. Reticular degeneration occurs when this balloon cells this swollen balloon cells rupture, leading to reticular degeneration. So this balloon cells may be multinucleate, which produces Sang cells. The coalescence of cells with reticular degeneration leads to multilocular vesicle. The septa of these vesicles are formed by residual cell membrane. Then in the center of enlarged nuclei of balloon cells, there may be eosinophilic inclusion bodies. So the first image shows balloon cells in the floor of the blister, which is seen in herpes simplex or zoster or varicella, and the second shows intranuclear eosinophilic inclusion body, which is seen within the balloon cells. Coming to subepidermal blistering disorders, first is bullous pemphigoid. The histopathological finding here also depends on the age of the lesion. Early lesions may show papillary dermal edema with cell poor or cell rich perivascular lymphocytic and eosinophilic infiltrate. The blister here arises at the dermo-epidermal junction. So it shows two distinct patterns, which may be cell rich or cell poor pattern. The cell rich pattern clinically corresponds to blisters arising on an erythematous skin. It shows eosinophilic papillary abscesses, numerous perivascular interstitial eosinophils, lymphocytes, and a few neutrophils in the superficial and deep dermis. and early lesions may show eosinophilic spongiosis. The cell pore pattern, it clinically corresponds to blister developing on a relatively normal skin. It shows scanty perivascular lymphocytic infiltrate with few eosinophils which are scattered throughout the dermis or near the epidermis. The blister lumen contains few inflammatory cells. So the first image shows subepidermal blister containing inflammatory cells. Second is arterial stage of bullous pemphigoid showing numerous eosinophils. And third is the zoomed in image of the first image showing fibrin, eosinophils and mononuclear cells. Mucous membrane pemphigoid or cicatricial pemphigoid. It also produces subepidermal blister with variable cellular infiltrate depending on the age of the lesion. So in lesions less than 48 hours, neutrophilic microabscesses are seen in the dermal papillae. As the age of the lesion increases, number of eosinophils increases first and later lymphocytes increases and the number of neutrophils decreases. Eosinophils, the number of eosinophils are fewer than in bullous pemphigoid, and scarring may be present if the biopsy site corresponds to an area of previous blister formation and subsequent scarring. So new collagen, this scarring may be seen as new collagen bundles which are arranged parallel to the surface than the usual haphazard arrangement of collagen. Then presence of sebaceous gland within the blister is a clue to the diagnosis of cicatricial pemphigoid because this occurs because of the extension of blister along the edge of pilosebaceous unit. So the image shows mucous membrane pemphigoid with subepidermal blister and scar tissue. Next is dermatitis herpetiformis. The early lesions of dermatitis herpetiformis shows collection of neutrophils and a varying number of eosinophils at the tip of edematous dermal papillae, leading to formation of papillary microabscesses. So these papillary microabscesses are seen at the blister periphery. That is why the preferred site of biopsy for dermatitis herpetiformis is the perilesional skin. Then at 36 to 48 hours duration, the number of eosinophils in that infiltrate increases and some fragmentation of neutrophils is also present. Older lesions shows subepidermal vesiculation, initially multilocular vesicle, and it becomes, after few days, it becomes unilocular because of the breakdown of the attachments within the multilocular vesicle. The vesicles of DH may contain fibrin, neutrophils, eosinophils, and very occasionally shadow epidermal cells. The papillary dermis beneath the papillae show relatively intense inflammatory infiltrate of neutrophils and some eosinophils. So the image shows microabscesses in the dermal papillae in case of dermatitis herpetiformis. Linear IgA bullous disease. Here also there is subepidermal blister with predominance of neutrophils like dermatitis herpetiformis. The early urticarial papules of plaques shows neutrophils aligned along the basement membrane zone along with vacuolar change and some dermal collections. The fully developed lesions show subepidermal bullae with neutrophil present in the underlying dermis alone or with eosinophils. Over time, these eosinophils can become numerous, thus mimicking the histopathology of bullous pemphigoid. Then, when DH and linear IgA bullous disease are compared, it is impossible to distinguish them by light microscopy, but linear distribution of neutrophils along the basement membrane zone and neutrophils at the tip of dermal papillae usually favor linear IgA bullous disease. Bullous lupus erythematosus. The early lesions show non-specific changes and well-developed lesions shows changes similar to that of subacute cutaneous LA. That is hydropic degeneration of basal cell layer, edema of upper dermis and extravasation of erythrocytes. There may be fibrin deposits in the connective tissue of the skin which is seen in erythematous lesions clinically. They are granular, strongly eosinophilic, PAS positive, diastase resistant deposits which are seen between collagen bundles in the walls of dermal vessels, in the papillary dermis or beneath the epidermis in the basement membrane zone. Then subcutaneous fat may also be involved in bullous LE and it may produce changes similar to lupus profundus but usually milder. So the image shows subepidermal split containing numerous RBCs and marked neutrophilic infiltrate in the papillary dermis. The insert shows positive lupus band test at basement membrane zone. Epidermolysis bullosa. Standard light microscopy has no role in the diagnosis of classic forms of inherited epidermolysis bullosa. 4 major inherited variants are there: intraepidermal or epidermolytic, that is epidermolysis bullosa simplex. Here, though the split is intraepidermal, the cleavage is so low in the epidermis that it leads to cell-poor subepidermal blister formation, or in localized variant, the split may be at the level of mid or upper epidermis. Then intralaminar lucida or junctional, that is junctional epidermolysis bullosa. Here it appears as subepidermal cell-poor blisters with pars positive basement membrane in the floor. Then sublaminar densa or dermolytic, which is epidermolysis bullosa dystrophicaens. These are cell-poor subepidermal blister with superficial dermal scarring and milia. And fourth is Schindler type of epidermolysis bullosa. Then epidermolysis bullosa acquisita is a non-hereditary form. It may be inflammatory or non-inflammatory. The most common form of EBA is bullous pemphigoid-like presentations clinically. Here, subepidermal blisters are seen, which are inflammatory with lymphocytes and neutrophils predominance and eosinophils in variable number. The classic form of EBA shows subepidermal blisters that are non-inflammatory, leading to subsequent fibrosis and milia formation. Lastly, spongiotic dermatitis. The acute and subacute variant type of spongiotic dermatitis usually produces vesicles or bullae. Here I have made a comparison of acute, subacute and chronic type of spongiotic dermatitis. In epidermis, in acute it is of normal thickness, whereas it is moderately acanthotic in subacute, while in chronic it is hyperkeratotic with areas of parakeratosis, wedge-shaped hypergranulosis and moderate to marked acanthosis. In subacute, this parakeratotic stratum corneum contains aggregates of coagulated plasma and scattered lymphocytes and neutrophils, leading to crust formation. Spongiosis. In acute, there is variable degree of spongiosis which varies from mild to marked. In marked spongiosis, there will be intraepidermal vesicles, and there will be exocytosis of lymphocytes into the spongiotic foci. The surrounding keratinocytes here shows stellate shape, which is surrounded by clear spaces which indicate fluid collection. In subacute, there is mild to moderate spongiosis, occasionally with microvesiculation, and in chronic, there is minimal focal spongiosis. In dermis, in acute variety, there is papillary dermal edema and superficial perivascular lymphohistiocytic infiltrate. In subacute, the dermis shows superficial perivascular lymphohistiocytic infiltrate, but it is less prominent than in acute phase. And in chronic, the infiltrate is sparse with papillary dermal fibrosis, which being a prominent feature. Other findings reflect lichen simplex chronicus with vertical streaking of the thick papillary dermal collagen. So the image shows spongiotic. This is a schematic diagram showing spongiotic dermatitis, acute and subacute variant showing vesicles. So there is vesicle formation, intraepidermal vesicle formation, spongiosis showing rounded cells, and eosinophils and lymphocytic infiltrates. So the image red arrow shows intraepidermal vesicle occurring in spongiotic dermatitis. Thank you.